Hi, good morning. Hello, Dr. Nemeth.
Can you hear me?
Yes, I can hear you. I can see you too. Hi.
Unfortunately, I don't have a camera, but Kyle obviously has a camera. I don't know if he's, oh, there's Kyle, perfect.
Okay.
Nice meeting you.
Nice to meet you. Thank you for joining us today and for being able to provide this lecture together with Kyle. Thank you.
Kyle is super keen and he's done a great job. We've been back and forth with the presentation, and it's going to be very educational and very beneficial for everybody, I hope.
Thank you. Thank you. I really appreciate it. We have Bangladesh local team, and this is a topic that they wanted to see.
Great.
Kyle, you're good with your audio visual?
I'm just getting it set up here. Sorry.
Hey, Denise, can you hear me?
Yes, I can hear you.
Oh, amazing. Okay, I just made you the host, so you should have full control of the meeting now.
Okay. So is it already recording?
It is already recording, yeah.
Okay.
And it's going to save. It's set up so it should save automatically to the cloud like it has in the past.
Oh, okay, that's great. Thank you.
Okay. Should I test my slides here?
Sure, you can share your screen for your
Sure.
slides.
Who are you? What are you doing? Okay.
Are you seeing my slides?
Yeah, we are.
Great. Okay.
So guys, how we sort of proposed it, if it's okay with you, is that Kyle will give his talk, and then we'll do the question and answer after the talk. Is that okay?
Yes, that works. That works. Yes, thank you.
Kyle, do you have your phone next to you? Keep your, because I'm going to be texting you in case there's issues, okay? So just keep it next to you so that you can see if there's any prompts or anything, okay?
Sure. Yeah, that's great.
Dr. Nemeth, has you volunteered with us in the past, or not yet?
I have not. I've heard about you guys through colleagues and I guess maybe conferences, but no, I have never volunteered with you guys specifically.
We would love to have you, of course. We do. We have sustainable. We provide health services. Primary care, pediatrics, surgical care. We currently have 3 sustainable programs in Bangladesh, Greece, and Colombia, and we are establishing our sustainable programs in Yemen and Sudan as well. And we have done several missions to Lebanon, to Kurdistan, to Syria, also Pakistan, and we are very interested now to include education because we really believe in sustainability, and education for our local staff is very important for us. We currently have a Helping Babies Breathe program. We have done training in Bangladesh and Pakistan, and also point of care ultrasound. So we are really glad to have this lecture with Kyle and with you and Kyle today. So really, really thank you. And we hope when everything gets back normal, we can have you in our programs as
Absolutely. It's your name is pronounced Denise or Denise?
Denise, yes.
Denise, first of all, it's probably the best 2-minute introduction and sort of summary of somebody's mandate that I've ever heard. So that's incredible. I understood. I knew about all this, but if I didn't, I would have understood everything in those 2 minutes. So that's perfect. So I just want to commend you for that. And absolutely, I do a lot of. I've done a lot of international work. And I love education, and so absolutely I would be very interested in providing and collaborating with you. As you may remember or know, I do adult and pediatric emergency medicine and trauma, and I teach POCUS as well. So it's perfect collaboration. And I have people like Kyle that are keen on also collaborating. So it's good.
For being here, for being willing to. Sorry, Kyle. Yes.
Oh, no, please continue. Please continue.
Yeah, I was going just to thank Dr. Nemeth to be here and also to introducing you to give this talk today.
Oh, thank you. I don't know if the whole group is there yet, but if we had a couple moments.
I was texting this to Blair if we can open.
Yeah. If they're not here yet, I'd be curious if you can give us a brief situation of where in Bangladesh are participants from and what's the context, because that's something I was really hoping to know more.
Yeah, thank you. Thank you for asking. I should have said this also. In Bangladesh, we work in Cox's Bazar. In Cox's Bazar, there's the largest refugee camp in the world. It's called Kutupalung Refugee Camp. And the camp is divided by sections. We work in camp number 4. This is where our clinic is located. And we have local staff there comprised of doctors and nurses and physician assistants. And they are the ones attending the call today. And we provide, at the clinic, we provide mainly primary care to both primary care and pediatric care to the refugees in Cox's Bazar. And last year, as I mentioned, we were able to teach Helping Babies Breathe to midwives in Bangladesh. We trained, I think, I don't remember the number, but almost 150 midwives in Bangladesh. And yeah, I mean, we have that. We've been in Bangladesh since 2017, and that is our one of our sustainable missions. We used to receive volunteers from all over the world to collaborate with us at the clinic. So this clinic is very, very important for us.
So is it a primary care clinic primarily, or is there, how much access is there to blood work, ultrasound, CT, and even MRI? Yeah.
So the clinic has very limited resources. We do have labs, but limited labs. If they need imaging studies or more complex interventions, there is a hospital nearby. So yeah, we do provide only primary care.
Okay. How far is the hospital, and what is accessible at the hospital?
The hospital is also located in Camp 4. I don't know the exact services of the hospital.
Sure.
But those are that hospital is usually the one that is used in the camp when there is when a referral needs to be done.
Okay. Okay, sounds good.
Thank you.
Close for us, but if you're making a test, you can. Yeah, I'm not sure.
And today's participants are all locally trained Bangladesh doctors. Is that right? Yes. Okay.
I think we can begin. Let me just confirm with our team. Okay, yes, we can start. Our current team, I wanted to let you know, is comprised of 2 doctors, 1 nurse, and 1 physician assistant. They work at our clinic together with our local partners, which are OVAT and Prantic, which are local organizations. So thank you, everyone. So we can start the webinar. Let me just give a small introduction of the team and the team that's going to be providing the lecture today. Thank you all to participating in this webinar today. We are very lucky to have Dr. Joe Nemeth. He's an associate professor of emergency medicine and pediatrics and a trauma team leader. He's the director of the Trauma Fellowship of Emergency Medicine at McGill University for over 20 years. He divides his time between adult and pediatric emergency medicine and trauma. And also part of his team is Dr. Kyle. He is an emergency medicine resident at McGill University, and he's very passionate on education. He will be providing the lecture today, so we are very lucky to have Dr. Kyle today as well. Okay, Dr. Kyle, thank you for this. Yeah, the floor is yours. You can begin your presentation. Thank you. At the end,
thank you.
I just want to say this to the team. At the end, we're going to do our Q&A section. If you would like to ask a question, you can either write it down on the chat, or you can also let us know to if you would like to talk, so I can give you access to be able to ask the question yourself. Thank you.
Yeah, and I really want to emphasize the question and answer piece. I really do want to have a conversational element to this, hopefully at the end, because getting to know your context in Bangladesh is just as important, and the free flow dialogue afterwards is just as important, in my opinion. So hi, my name is Kyle Ng. I'm a 3rd-year emergency medicine resident here, which means in Canada, I'm a fully trained primary care physician like yourself, and I'm doing an extra year in emergency medicine. And today we'll be talking about headaches, especially as it pertains to secondary headaches, life-threatening headaches, things beyond your simple migraine. So just some quick disclosures. I have no commercial interests. I am, however, Canadian and trained, so a lot of what I will be speaking from comes from that perspective, and all the kinds of imaging and decision-making rules that are available to me in a Canadian context. Hopefully some of them can translate and apply for you, but I'm happy to discuss how they may or may not afterwards for sure. So our objectives today, just to highlight a few key objectives, we're going to be talking about differential diagnoses of headache, focusing on the concerning signs and symptoms and special populations, and a review of some of the treatment modalities for life-threatening headaches and common headache presentations. And then we're going to be talking a bit throughout, and as well as a review at the end of the sort of recommended testing modalities under and more of a discussion about how to do so in a resource-limited paradigm, which is piece, we're going to be talking about a case right here just to frame our discussion. So a 23-year-old male walks into your clinic with a severe headache. He's healthy otherwise, medical history, allergies, or medication. Is that he developed a sudden onset of a severe headache at work while lifting a heavy object. He took some aspirin and about 2 hours later, his has been resolved now that he's been sitting in your clinic or emergency department waiting room. When you get to see him, his vitals and exam are completely normal. And so what would you do in this case? Is this concerning? Is this not? That's going to be our discussion today. So just a quick approach to headache in terms of the things that we really don't want to miss. The first one to emphasize is a thunderclap headache, and here is defined as a 10 out of 10 worst pain of your life from 0 to 100 in 1 second would be the definition of a thunderclap headache. And if yes, that puts you down a certain pathway. Another particular pathway would be the fever, altered mental status, neck pain, and stiffness pathway. And of course, that's talking about infectious causes and highlighting that possibility as a separate pathway. And then a sort of miscellaneous other concerning features that I'll go into this next slide as things to keep in mind while you're evaluating the patient. So these red flags can be anything from sudden onset, trauma, exertional, some of which our case had, altered mental status, seizures, fevers, neurological symptoms, or visual changes as to particular symptoms. If they're taking particular medications such as anticoagulants, recent antibiotic use, or immunosuppressants, they might highlight a particular bleed or infection risk. And then past medical history of no prior headaches, associated conditions such as pregnancy, inflammatory diseases, vasculitis, cancers. And then of course your physical exam findings of altered mental status, fever, neck stiffness, papilledema, and focal neurological signs are all very concerning. Certainly something to keep in mind. And so up here, these are what we call in a Canadian context red flags. Here we've sort of defined the concerning features, really just to bring up to the forefront concerns for a potential life-threatening cause, keeping your sort of sixth sense of whether or not something extra beyond a simple headache that this person might be presenting with. And those, of course, are pointing at these particular life-threatening diagnoses, which we'll go into more at length. Intracranial hemorrhages, dissections, thromboses, encephalitis, meningitis, abscesses, vision-threatening conditions such as giant cell arteritis, angle closure, glaucoma, and raised intracranial pressure conditions such as masses, hemorrhages, abscesses, etc. So we're going to be going through these at length, but that's the link between the concerning red flags, concerning features that then point to our life-threatening diagnoses that we want to keep in mind. So our differential can be broadly categorized into these 6 that we've sort of highlighted here: space occupying bleeds or masses, vascular or thrombotic differentials, infectious differentials, inflammatory differentials, metabolic, which is really mostly carbon monoxide in this context, and pregnancy as our 6 major categories that we'll be going through today. In terms of space occupying bleeds, our big one that's part of our don't miss category is subarachnoid hemorrhage. And that's classically what is associated with a thunderclap headache. That 0 to 100 in 1 second is what we think about here. They can also be associated with loss of consciousness, neck pain, or stiffness. And then our other categories of space-occupying bleeds are your intracranial hematomas, your epidural hematomas, and subdural hematomas. There's a wide spectrum of how these present, but typically trauma or either acute or subacute trauma is usually how these individuals present. Of course, if they have risk factors such as being elderly or have significant alcohol use, it could be even less trauma can produce these hematomas, and they'll often present with loss of consciousness, nausea, vomiting, drowsiness or confusion, seizures, and then if they're severe, we're talking about uncal herniation, then ipsilateral pupil dilation or Cushing reflex, where the blood pressure will go very high and the heart rate will go very low, will really are the concerning signs of impending herniation. So this is just a slide to talk about traumatic brain injuries, and really to talk about the fact that we won't be talking about this very much because that can be a whole topic in of itself. The only thing we want to highlight here is that there are specific clinical decision-making rules in this context where somebody has an acute head trauma. Do I want to scan their head or not? At least in the Canadian context, we use this a lot, where this is called the CT head rule, developed out of Ottawa, and the PCARN for children. These are both available in a free app called the MD Calc, and you can find that there, and we can discuss that more if that's of interest. What I wanted to talk a bit more was the Ottawa subarachnoid rule. This is also a clinical decision-making rule, and that's really more applicable to our patient case here, where they had a sudden onset headache. Do we need to scan them or not? Do we need to LP them or not? It can really help with that decision making. So this is for alert patients, a new headache with an onset peaking within 1 hour. Who they've excluded from this rule are those who are children under the age of 15, if they have a new neurological deficit, if they've had previous aneurysms or tumors, and if they've had a history of recurrent headaches. And the rule would basically say that if you have neck stiffness, you're 40 or above, you have loss of consciousness, it has, they have onset on some sort of physical exertion, peaking in 1 second, which is that thunderclap headache, and if they have limited neck flexion, then those are all the categories, as you can see here. You check one of those and they will bring you to the next slide here, which will tell you to go down and CT this patient. And if they did not have any of those criteria, no CT would be required. You're able to safely say that that's a low risk headache, we don't need to image. And then if you're able to image this patient within 6 hours of their onset of symptoms, then you're done. No further investigation is needed. Otherwise, if the scan was equivocal, nothing was found, but it was past 6 hours, then we're going to have to LP this patient. And if you have concerning signs in the LP of xanthochromia or a high number of red blood cells, then you're going to need angiography to further delineate the lesion. And so that rule is also on MD Calc. There's a dedicated Ottawa Rules app, if you, which is where these particular slides are from. That's from the makers of the actual decision-making rule. So as we're talking about in the subarachnoid hemorrhage domain, CT and or LP is going to be your modalities of choice. And if you were to find a subarachnoid hemorrhage, then the mainstays of therapy are to control their blood pressure, keep the systolic under 160, keep the MAP under 110, reverse any anticoagulation that they might have been on, and then consider a calcium channel blocker like nibodipine for prevention of vasospasm. And so here we talk about epidural and subdural hematomas, the mainstay of diagnostic modality is a CT scan, non-contrast is usually enough. And then a surgery is the mainstay of therapy here, if accessible. If not, in the meantime, reverse their anticoagulation, prevent their secondary injury using ATLS paradigms, such as raising the head of the bed, keeping their blood sugar within the normal range, keeping their blood pressure within the normal range, using mannitol or hypertonic saline. And if you're really in a pinch, you're trying to get them to definitive care and they're herniating, then getting their PCO2 lower by hyperventilating them is an option to consider. And of course, definitive management is neurosurgery, and if you're stuck, there's nothing else, then consideration of a burr hole is possibly in your arsenal. Next here, we talk about vascular and thrombotic differentials. So closely related in our trauma setting is cerebral artery dissection, vertebral artery dissections, and carotid artery dissections. They're typically with neck trauma, though not always. And they'll have neck pain. They can possibly have strokes-like symptoms, either posterior or anterior, with dizziness and vertigo and coordination. In a posterior stroke, that would be pointing at your vertebral artery dissection, or in an anterior stroke symptom, more typically hemiplegia, slurred speech, ptosis, meiosis, that's pointing at your carotid artery dissection. And then on the flip side of that, in the venous system, with clots, you'll have cerebral venous thrombosis, and those are associated largely with headache, as we're talking about, but they'll also have raised ICP symptoms, papilledema, cranial nerve deficits, and possibly seizures. With cerebral artery dissections, we want to suspect this with their presentation in a trauma context, either head, face, or neck trauma, or with their sort of stroke-like symptoms, you want to consider that. And so CTA, MRI, MRA are going to be all your modalities, whichever one is most easily accessible and readily available. And if found, then aspirin, and if more severe, IV heparin are your modalities of choice. And they don't often go to surgery with, but chatting with a neurosurgeon or a vascular surgeon about the possibilities of needing surgery is important. And for cerebral venous thrombosis, these are rare, but certainly very life-threatening. So we wanted to talk about this. You suspect this with individuals with previous clots, family history of thrombosis, cancer, connective tissue disease, trauma, oral contraceptive pill use, or pregnancy. So really, think of it almost like a DVT of the brain, and same sort of mindset and risk factors apply here as well. And to diagnose this, you would need a multi-phase CT, a CT venogram, so that delay the contrast until it's in the venous phase to see this better. Or else even better would be an MR venogram. Anticoagulation is also the modality of choice here. Heparin or low molecular weight heparin would be how you would treat this. Next, we move on to space-occupying masses. So brain tumors are going to be your most significant diagnoses in this category. They actually rarely have headaches, but nausea, vomiting, constitutional symptoms, papilledema, focal neurological deficits, and/or seizures are the cluster here. And the major differential here is idiopathic intracranial hypertension, for which we won't talk a lot about, but basically it's raised ICP without a defined lesion inside the brain, and you'll have double vision, flashes of vision, typically in overweight females. They can present with papilledema, of course, cranial nerves, especially cranial nerve 6 palsy, and pulsatile tinnitus. So just a quick slide here about papilledema. Of course, it's, as we know, very difficult, time-consuming. They need dilatation, we often have bad equipment, and this produces a vicious cycle where we does this less and less, and we get worse and worse at it. We get more and more scared of it. Certainly, I can admit that I'm not great at ophthalmoscopy myself, but somebody with a new onset headache, and we don't know if there's raised ICP or not, and it could be one of your tools if you don't have imaging readily available. Traditional ophthalmoscopy is going to require dilatation. If you have access to a panoptic or new tools to be able to look into the fundus without dilatation, that's great. And to take images of the fundus would be even better, so that you can share it with your consultants and have a discussion. This is just a quick slide about the different gradations of papilledema. This is the Friesen scale, but the scale is not so important as it is just to recognize the different presentations and how severe it can get. The traditionally talked about the cup to disc ratio, and here the main thing highlighted is the erosions of the major vessels on the disc. As it gets more and more severe, you'll see the vessels get more and more eroded, and that's a hallmark of severe papilledema. Papilledema can also be controversially diagnosed in a POCUS format. So as Merge Doc, we're always trying to put new utilities with our ultrasound probes, and this is an emerging one to assess raised intracranial pressure and or papilledema. So what you do is you put your linear probe, your high resolution probe, on the eye with a tegaderm dressing on the eye to protect it, getting the air out as much as possible, putting some gel in it to make that interface with your probe. You line it up in a transverse approach, and you look just deep to the retina here, 3 millimeters deep. You're looking at that optic sheath, and if that measurement was 5 millimeters or more, it is suspicious for raised intracranial pressure. Here we have a slide from the POCUS Atlas talking about the sensitivity and specificity, and as you can see, actually pretty good, 95% sensitive and 92% specific for intracranial pressure. And to raise that sensitivity and specificity even better would be if you raise that cutoff to 6 millimeter, because a lot of people are actually in that equivocal space of 5 to 6 millimeter. But if you're in that equivocal space, this is a algorithm by Josh Farkas at MCrypt and PalmCrypt. He suggests that if you're in that equivocal space and you're able to delineate whether or not there's actually this bump here suggestive of papilledema, then especially if it's bilateral, then you can more definitively say that this is raised ICP. And if there isn't, then this might be actually pseudo papilledema, maybe something of the optic nerve, and the ICP is probably normal. So your differential here is actually optic neuropathy, nerve papillitis, and nerve tumors that can also affect your optic nerve and not actually give you raised ICP. So it's something to keep in mind. Of course, this is a slide highlighting what possible intracranial mass can look like. And I just put this here just to share that I had a case myself at the Montreal Children's not too long ago. I believe actually it was with Dr. Nemeth, where a kid came in with isolated papilledema found on routine in an optometry setting, and he only had a mild headache retrospectively, now that he thinks of it, but that was it. And he had this massive brain tumor. It's a similar situation to his. All of this is to say, just to highlight how important papilledema and eye exams can be. For tumors, your diagnostic modality of choice is a CT or ideally even an MRI scan to delineate that edema and the soft tissue swelling. Neurosurgery is, of course, your definitive management, and if you're trying to temporize the swelling, the raised ICP, then consideration for steroids is appropriate. For idiopathic intracranial hypertension, we won't go through this super ton, but to diagnose it, you do need a CT venogram or MR venogram to give you suspicion for that, and then the definitive diagnosis is actually made on LP with an initial opening pressure is how you would diagnose this condition. They need often neurology or neurosurgery to be involved, acetazolamide and Lasix to be able to drain that, to decrease that pressure. And there's some controversy in the literature, but traditionally serial LPs and steroids are also considered for this condition. Next, we talk about infectious causes, and viral encephalitis and bacterial meningitis are going to be our big categories here. Very difficult to differentiate sometimes, is what we want to highlight, because it's going to be a mixed picture. But confusion, headache, fever, nausea, vomiting, decrease of consciousness, seizures, can present for viral encephalitis, and then of course very similar things to bacterial meningitis, except you're going to have nuchal rigidity. You could possibly have petechiae and purpura if they have meningococcal disease, and so think about that for meningitis. They'll also oftentimes be much more ill appearing than your encephalitis one, but hard to hang your hat on that one. So for our infectious disease workup, an algorithm from the IDSA, Infectious Disease Society of America, and they suggest that unless you have any of these concerning features, whether or not they're immunocompromised, they have a new onset seizure, consciousness, they have focal neurological deficits, previous massive strokes, infections, or signs of raised ICP, then you'd be safe to go directly to cultures, you'd be safe to go directly to cultures and a lumbar, and immediately after give steroids and empiric antibiotics. The main is to not delay antibiotics. So if it's incredibly hard to set up a lumbar puncture in your institution, it's going to take over an hour. Certainly don't delay even for that. Just take the blood cultures and go get the empiric antibiotics. If they do have these concerning features, then the main emphasis here is they're going to need a CT scan just to be able to rule out a intracranial mass, intracranial lesion, or abscess that can be creating a pressure difference between the spine and the brain, such that once you put that needle into the lumbar space, herniation can occur because of that pressure difference and sudden outflow of CSF. So in those cases, you want to give blood cultures. Don't delay for the scan and LP in that case, and just give the antibiotic for cells, glucose, proteins, culture in your LP, and if they have signs for bacterial meningitis, then you'd want to certainly continue therapy. So in terms of therapy for encephalitis, we want to consider acyclovir as our mainstay of therapy because it's certainly the most readily treatable, and large majority of cases are going to be HSV or varicella encephalitis. Well, not necessarily large majority, but those are the majority of the treatable ones. We wanted to highlight here also Bangladesh specific diagnoses and differentials. So out of the CDC Yellow Book, which you can all tell me more about really happy to hear about your experience with these diseases, but Japanese encephalitis and dengue as your viral causes, that the mosquito-borne vectors with supportive care as their primary management, cerebral malaria. In your context, my understanding is it's 90% falciparum with resistance to chloroquine as noted, and artemisinin therapy is therefore the main line of therapy of choice, and leptospirosis as the other main consideration as a cause of headache, not necessarily encephalitis commonly, but can be. And this is a waterborne disease that you'll want to treat in a mild context with doxycycline and azithromycin, and in severe cases with IV penicillin, ceftriaxone, or if available, IV doxycycline. And this is a slide on the bacterial meningitic causes to cover. So the last slide being viral and treatment with acyclovir. This one about bacteria. So the primary take-home point in this slide is really to have guidelines and therapies be dictated by your local antibiogram if available, and local dose guidelines if available, because certainly even for things like vancomycin in Canada, I know in certainly British Columbia, we don't always routinely give vancomycin because the resistance of strep pneumo to vancomycin or to ceftriaxone is actually not all that common. So, so if available, use that, but generally speaking, in the absence of local guidelines, you'd want to use ceftriaxone 2 grams IV Q12 as opposed to your usual dosing of 2 grams IV Q24 for meningitic dosing. Cefotaxime as an alternative third generation cephalosporin if available. For young populations less than 1 month old, or the less young, you're over 50 years old, or individuals with alcohol use or other risk factors, then you'd want to consider adding ampicillin 2 grams IV Q4 or 300 to 400 milligrams per kg in children. Vancomycin is to cover, like we were saying, about strep pneumo resistant to ceftriaxone. That's going to be 30 milligrams per kilogram dosing for loading dose. And as we talked about, 10 milligrams per kilo per dose Q8H. So if for someone very, very sick, obtunded, they're a bit old, we're going to throw all 4 of these. Little kidneys are just to remind us that there is renal dosing for these 3, but certainly for your first dose in the first hour, don't worry about renal dosing. Just give them the full loading dose and figure out. So giant cell arteritis is our topic, namely our inflammatory differential. So with giant cell arteritis, think of it for your over 50-year-olds, very rare in younger people, arguably non-education, visual loss, diplopia, and temporal artery bruits or on exam can certainly point you towards giant cell arteritis. And our differential here is not really inflammatory, but in the vision loss, ophthalmological differential, you have acute angle closure glaucoma, and these present with monocular pain that is acute on onset. Certainly decrease in vision, headache that's so severe that they can't really localize it to the eye itself. It's just generalized headache, nausea, vomiting, eye redness, dilated pupil, steamy cornea, which we'll take a look at in a second here. If you're thinking about it, ESR and CRP are going to be your first line tests. Certainly not impossible to have ESR or CRP negative So if you're suspecting it, it's not entirely a rule out with these being negative. The definitive temporal artery biopsy, but more and more now we're moving towards the availability of Doppler ultrasound as roughly equivalent, and that under the European Society guidelines, they've actually recommended that as both simultaneously as good. So again, another ultrasound slide, but available to you, formal ultrasound, but if not, just slapping the probe, a point of care probe to see if there's what's called a halo sign right around the artery here. You'll see the pulsating Doppler with this significant ring of dark shadowing around it of halo, signifying inflammation around the actual artery. You can also have stenosis of the temporal artery, or if you look in the other arteries, the axillary artery, you can also see similar lesions, but halo sign is probably going to be the easiest thing to identify. And if they have bilateral halo signs, even better. I'll give you even more confidence that this might be giant cell arteritis. Steroids are your first zone, 50 milligrams daily for up to a month, and then slowly tapering it depending on their symptoms. And if they have visual symptoms, to consider IV methylprednisolone for pulse, 1 gram per day for at least 3 days before switching over to. They'll need long-term follow-up rheumatology, of course, to manage all the side effects of steroid use, as well as if they haven't gotten it already, definitive temporal artery biopsy for diagnosis. So acute angle closure glaucoma here is this next slide. So the steamy cornea, this is what we were talking about before, this cloud over the cornea would certainly point you towards this, otherwise a red eye, fixed dilated pupil. If you see this, try to get a intraocular pressure with device, or just even simply palpating the eye to see if there is a noted difference of rigidity there. They're going to need a gonioscopy or slit lamp exam, ideally by an ophthalmologist, to diagnose this condition, but emergently you're going to be able to treat this with timolol drops, aproclonidine drops, pilocarpine drops, and acetazolamide, PO or IV. And these are all basically that aqueous humor production in the chamber, and hopefully produce outflow to be able to decrease that angle closure and intraocular pressure. There's also consideration for mannitol if these therapies aren't really working, and they'll need definitive therapy with an ophthalmologist, namely a laser iridotomy, to be able to open up that space to have the aqueous humor drain. Next, we move on to metabolic causes. So carbon monoxide really is the main diagnosis in this category, and importantly for this, primarily because you can arrive at a mass casualty situation if you have multiple people walking through your doors in the same household or in the same building, and they all have the same symptoms: headache, blurry vision, nausea, vomiting, perhaps syncope, perhaps confusion. Then think about carbon monoxide poisoning. Certainly one of your not misses there. So this is an abbreviated algorithm from UpToDate, but your ABG is going to be your main diagnostic tool, and if not available, then a VBG to get your carbon monoxide hemoglobin level. And if they have more significant symptoms, nausea, vomiting, blurry vision, then you're going to want to give them high flow oxygen, lots of oxygen, to be able to flush out that carbon monoxide from their system. There's a separate algorithm here from UpToDate to consider hyperbaric oxygen. This is just an abbreviated version, but within certain criteria, and if available to you, then for more severe cases, you can consider hyperbaric oxygen chamber therapy. Finally, we're talking here about special populations, namely our obstetrical pregnant population. So as you all know, preeclampsia can certainly provide you with a headache. So suspect it's with individuals 20 weeks gestation or more, or even in the postpartum period. If their blood pressure is over 140 with proteinuria, that's already your diagnostic criteria. And then severe preeclamptic features of thrombocytopenia, renal insufficiency, impaired liver functions, your HELP eclampsia are going to be your diagnostic signals. In your differential, not necessarily of preeclampsia, but in the sort of postpartum phase, you can have Sheehan syndrome. That's pituitary necrosis, secondary to large postpartum hemorrhage. And sort of related to that is pituitary apoplexy, which is more of a hemorrhagic destruction of your pituitary that can be associated with pregnancy, but can also not. So headaches, vision change, and they're often in the postpartum areas. And finally here we've added post-dural puncture headaches as something to think about if the individual has had an epidural or even for another, not just for pregnancy, then a headache worse while sitting or standing sort of would point you towards that. They might have nausea, vomiting, auditory disturbances, vertigo, neck or back pain. This is more of a diagnosis of exclusion because there's not really any diagnostic test for this, but if they do have a dural puncture, then think about this as a possibility. So recapping just for preeclampsia, you'll want your usual preeclamptic workup, your urinalysis to look for proteinuria, and the definitive management is going to be just deliver the baby if possible. Controlling their hypertension in the meantime with hydralazine, labetalol, nifedipine is going to be important. And especially if the baby is already delivered, then really that's your mainstay of therapy. And have a seizure, they go to eclampsia, then magnesium is your therapy of choice there. Pituitary apoplexy or Sheehan syndrome is going to be diagnosed with CT scan, or better yet, because it's such a small lesion and can be subtle, MRI is a better modality if available. Neurosurgery and endocrinology will want to be called for this. And if they're really sick, namely hypotensive because of their adrenal insufficiency, then hydrocortisone is your mainstay of therapy here because so post-dural puncture headache, like we were saying, mainstay of therapy is going to be a blood patch, ideally administered by an anesthetist. And this is a slide just to recap the imaging guidelines that we've talked about already, really, all throughout this talk. From the American College of Radiology, and it just talks about how for a number of diagnoses, which imaging modality is appropriate and which are not. I'm just going to go through the ones that are appropriate or may be appropriate. There's a long list of the ones that are not appropriate, and you can find them in the attached reference. So for sudden severe headache or worst headache of their life, so thinking again of that thunderclap headache, CT's head without contrast is usually appropriate. CTA with contrast can be considered maybe appropriate. A new headache with optic disc edema, so papilledema, MRI with or without contrast is usually appropriate, and if not available, then CT head without contrast is also appropriate. New progressively worsening headache with one or more of the following red flags. So what we were talking about, those are figure of speech that says concerning signs, think of something more severe. So subacute head trauma, related activity, neurological deficit, known or suspected cancer, immunocompromised, over 50 years of age, currently pregnant, or any of our other red flags that we talked about before that that you're suspicious of a secondary cause, and you'd want to consider a CT head without contrast as usually appropriate, and if available, an MRI with or without contrast. Chronic headaches that have new features or they are in increasing frequency can be an indication for imaging. So in those cases, you really want to have an MRI with or without contrast to delineate a secondary cause. Otherwise, a CT head with or without contrast can also be appropriate. So otherwise, besides those major categories, we really want to avoid imaging. So this is a slide highlighting that major societies in Canada and the US, the Headache Society, the American College of Radiology, all suggest don't order neuroimaging or sinus imaging in patients who have normal clinical exam, who meet diagnostic criteria for episodic migraine and have no red flags for secondary headache disorder. So I will go through this because this is essentially what we've been talking about the whole slide, the whole talk. But unless they have these concerning features, these red flags, then you can forego imaging. So even if it's a new headache, if they have a classic migraine or tension headache type primary headache, then no imaging is required. So just a quick slide about migraines. This is not the scope of this talk because we can talk on end about headaches. It's such a broad topic. On migraines as one of the more common primary headaches. So as you all know, headaches that are 4 to 72 hours long, that can be unilateral, nausea related, and incredibly disabling are the hallmarks of a migraine. Under our Canadian Headache Society guidelines, stays of therapy as first line would be NSAIDs, acetaminophen, so either ibuprofen, aspirin, naproxen, ketorolac, choose your NSAID of choice, and Tylenol, acetaminophen, 1 gram PO, and often mixed with Maxaran and some additional analgesia, then 10 milligrams IV or PO would be appropriate. And usually when I'm in the emergency department, that's my cocktail of choice, first line. You can add triptans for ones that are particularly severe, or if they're in the new onset acute phase, you can abort it with a triptan, so consider that. Or if they're refractory to your other therapy, then you can consider that as your second line. Triptan sub-Q is going to be a bit better than your nasal options, a bit better than your oral options. And then after that, you can consider dihydroergotamine. Try to avoid this routine use because the side effects are pretty severe, but 1 milligram sub-Q or 2 sprays in both sides or how you administer that. And then opioids, especially tramadol, codeine, or even morphine and dilaudid, you really want to try to avoid them routinely, mostly for the side effects and even its abuse potential. But if you're really stuck, then you can consider it. And dexamethasone is not really a treatment in and of itself. It won't rectify the migraine, but can prevent recurrence. Is what's found in the literature. So 10 milligrams IV of dexamethasone can be helpful in an emergency context. And this is sort of the emerging literature, sort of fun tip or trick. So lidocaine with a cotton tip, a proprietary syringe, or even just putting in drops of 2% lidocaine into the back of the sphenopalatine ganglion and putting the individual into reverse Trendelenburg can be a quick solve, can get them out of your emergency department faster than hooking them to an IV and waiting for the drugs to work. So if you want to give this a try, it's really, for the cotton tip applicator, really like a COVID swab. If you've done one of those, or else just putting drops of lidocaine into the back, letting them sit there for a couple minutes, up to 15 minutes, and they should start to feel relief already. So hopefully this talk didn't give you a headache, and hopefully it was helpful. Happy to take any questions and have a discussion about how you all approach your headaches and any questions you might have.
Thank you so much for this excellent presentation, Dr. Kyle. Let me see, I have someone who raised their hand, Dr. Rahana Parvin. She's our clinic coordinator. She would like to have ask you a question.
Sure.
Dr. Rahana, you're able. I think you're able to talk now.
Yes. Hi, Dr. Kyle. It's a nice presentation about the headache. I have a question that actually we know, and you also said that for the first slide, you said that some medication causes for headache, including that anticoagulants or antiplatelet drugs. So my question is, sometimes I've seen some doctors prescribe tablet aspirin for the treatment of headache. So my question is it safe to give tablet aspirin for headache, or what is the actually indication to give the tablet aspirin for the headache?
Yeah, so my understanding of what you're saying is aspirin is an antiplatelet, and so are we concerned about this in the context of treatment of headache, given that it can potentially muddy the waters, and in terms of whether or not we're concerned for bleed or not? Is that your question?
Yeah.
Yeah. So I think I think you're right in the sense that well, even in this second to last slide with migraine therapy, aspirin is on that list of potential migraine therapies. It is appropriate, but I think you're astutely pointing out that, hey, we have alternatives. Why not use just Tylenol and ibuprofen? I mean, ibuprofen, some people might swear that it also may increase a bit of bleeding, but I think in comparison to aspirin, I think it's really a bit less. So I think you're right. You have alternatives. Why not use something else?
Dr. Rahana, this is Dr. Namath. So I agree with Kyle. It's actually a very important question, and an excellent question. So in the context of migraines, remember we're talking about somebody who comes in with a clear history and of migraines. So we're not considering that this could be an intracranial bleed. In those patients, absolutely. Any non-steroidal anti-inflammatory medication is probably better than acetaminophen or paracetamol that you guys use. So I would definitely use either aspirin or ibuprofen or whatever non-steroidal anti-inflammatory you have. But I emphasize that this is patients who come in with a clear-cut migraine. For those that come in with undifferentiated headache, especially if you're entertaining any sort of intracerebral catastrophe, such as a bleed, a subarachnoid or traumatic bleed, I would stay away from aspirin or any of the non-steroidals because of exactly what Kyle says. We have alternatives. And I would like to highlight, I don't know if Kyle did or not, maybe he did, but Maxran or metoclopramide is a very non-specific and very few contraindications and side effect medication that will non-specifically relieve many headaches, including things like bleeds, including things like I've even seen viral meningitis, the headache resolved with metoclopramide. So so you can use it, but just know that even though the headache is resolved, doesn't mean that you're not dealing with something more serious. So that's sort of my take on using anti-inflammatory, non-steroidal anti-inflammatories, and using metoclopramide in a more widely spectrum basis.
Okay, thank you. I got it. And what should be the dose for the aspirin in case we find out any kind of like causes hepatitis, like it is 4-tablet state, like in our country we have 75 milligram preparation. So is it 4-tablet state?
So if you have no other choice as your non-steroidals, I would say aspirin is fine, but it's certainly not my go-to. My go-to would be ibuprofen 400 milligrams or ketorolac 30 milligrams IV if available. But in the Canadian Headache Society guidelines, they talk about aspirin 1,000 milligrams as actually appropriate. So quite a bit more than what you're using there.
Okay, I got it. Thank you very much for your answer and
Yeah, Dr. Rahana, I agree with Kyle that 75 milligrams is a baby dose. So you definitely need to use at least 325 milligrams, if not 650. And like Kyle said, even 1,000 milligrams. But anything above 325, I think would be needed to achieve any sort of anti-inflammatory effect.
Any more questions from the attendees?
Denise, if I can just comment that you have my email address. I have no problems with you sharing that with any of the participants. If right now they don't have questions and maybe they'll think of a question in a day or tomorrow or next week, they can email me directly, no problems.
Much for that. I facilitate that with them, and also Dr. Kyle, if you can provide us with the presentation to be shared with the team, we'll appreciate that as well.
Yeah, absolutely. And there's a bunch of notes as well with the slides. So yeah, happy to share them.
Okay, thank you so much. So at the moment, we don't have more questions from the attendees, but I'm sure they'll have more questions and they'll review this video and your slides. I'll share your email, Dr. Nemeth, with them. I really want to thank you again, Dr. Nemeth and Kyle, for giving this excellent presentation. Thank you so much.
Oh, our pleasure. Thank you.
Great job, Kyle. Thank you very much, everyone.
Thank you, everyone. Talk to you soon. Goodbye.